All right, let's get right into it. Today, we're tackling a very structured, high-yield explainer, specifically designed to answer the NMC guideline prompt SU22.2. Describe the etiopathogenesis of thyroidal swellings. We're going to completely bypass the fluff and jump straight into the cellular mechanisms and structural changes that define this absolutely essential pathology.
Now, this explainer is actually a special request from Pollock Goyle, a final-year MBBS student. So we're dedicating this deep dive to her. I also really want to acknowledge the excellent guidance of Dr. Bhavani Rao Sir at Gear Sar Vizag. His focus on structured, guideline-based learning is exactly what inspired today's breakdown of this crucial surgical pathology topic.
To answer an essay prompt like this effectively, you really need a mental map. So here's our agenda for today. 1. Classifying thyroid swellings. 2. Simple goiters and iodine. 3. Hyperthyroidism and toxicity. 4. Thyroid neoplasms. And 5. Thyroiditis.
Section 1. Classifying thyroid swellings. Let's lay down a solid foundation and figure out exactly how we group the different ways this gland can enlarge.
Okay, before things go wrong, we have to understand what's normal. The fundamental functioning unit of the thyroid is the lobule. Every single lobule gets its own arteriole and is packed with roughly 24 to 40 individual follicles. These follicles are basically the engines of our metabolism. They're lined with cuboidal epithelium and filled with this thyroglobulin-rich colloid. Under normal circumstances, TSH stimulates these specific follicles to proliferate. That physiological baseline, that's exactly where most swellings begin their pathological journey.
So when we classify these swellings, we can basically drop them into 4 main buckets. You've got your simple euthyroid goiters, toxic goiters driven by hormone overproduction, neoplastic swellings, which can be benign or malignant, and finally, inflammatory conditions like thyroiditis. We're going to unpack the etiopathogenesis of each of these, one by one.
Moving right along to Section 2, Simple Goitres and Iodine. This category fundamentally roots back to a really delicate balance between thyroid stimulation and our iodine intake.
The most crucial takeaway here is that a simple goiter is almost always a story of compensatory TSH stimulation. When circulating thyroid hormones run chronically low, the pituitary gland panics and just pumps out TSH to compensate. But why do those hormones drop in the first place? Well, it could be a dietary iodine deficiency, which we historically see in endemic mountainous regions. Or it could be dyshormonogenesis, a genetic enzyme defect that blocks hormone synthesis. And here's a wild twist. It can actually be caused by excessive iodine, which paradoxically inhibits the organic binding of iodine. Crazy, right?
So, let's look at how this compensatory trigger plays out at the tissue level. The pathogenesis of a simple goiter is this fascinating yet super destructive step-by-step cycle. First, you get diffuse hyperplasia. The whole gland grows uniformly because of that TSH. But the stimulation isn't perfectly steady. It fluctuates. So eventually you end up with a mixed pattern of active and inactive lobules. The active ones become highly vascularized, but they grow too fast, outgrow their blood supply, and undergo hemorrhage and central necrosis. Finally, all those necrotic lobules kind of merge together into inactive, colloid-filled nodules. It's just a relentless cycle of hyperplasia, hemorrhage, and necrosis.
When you look at the gross pathology, the direct result of that exact cyclical pathogenesis is incredibly obvious. You get this structurally chaotic, enlarged gland full of multiple nodules, formed by those coalesced necrotic lobules we just talked about. This tissue is highly prone to cystic degeneration and active hemorrhage. Most of the nodules are completely inactive, basically pushing whatever functional follicles are left into the internodular tissue.
Section 3. Hyperthyroidism and toxicity. Now we are totally leaving the euthyroid, simple goiters behind and entering toxic states where hormone production completely ignores normal feedback loops and just goes into absolute overdrive.
Notice the striking difference in how these 2 main toxic states develop. Graves' disease is primary thyrotoxicosis. It's essentially a system hack. An abnormal autoimmune IgG antibody binds directly to the TSH receptors, causing this diffuse, unyielding stimulation of the entire gland. On the flip side, a toxic nodular goiter is usually secondary. Imagine a patient who already has a long-standing simple nodular goiter. Over time, that internodular tissue gets highly overactive, or maybe a single nodule mutates into an autonomous toxic adenoma that completely rebels against the body's regulatory signals.
Clinically, because those TSH receptor antibodies stimulate the entire gland uniformly in Graves' disease, the presentation is a classic diffuse, smooth, and highly vascular hypertrophy of the neck. It feels very, very different from the lumpy, irregular texture of a multinodular goiter.
All right, Section 4, Thyroid Neoplasms and Cancers. Let's shift gears and look at the pathogenesis of neoplasms, separating the isolated benign adenomas from true invasive malignancies.
While it's true that most thyroid cancers don't have a glaringly obvious trigger, there are some very well-documented etiologic factors you need to know. The biggest one? Childhood radiation exposure, particularly if it happens under 5 years of age. Then, genetically speaking, specific oncogene mutations heavily dictate pathogenesis. For example, the RET/PTC3 mutation is linked to really aggressive, short-latency papillary carcinomas, whereas RET/PTC1 is associated with ones that develop much later. Also, in endemic goiter areas, chronic TSH stimulation is strongly linked to a higher incidence of follicular carcinomas.
To bridge the gap from textbook pathology to real-world clinical practice, you absolutely have to remember the rule of 12. It's brilliant for statistics. An isolated nodule, that carries double the malignancy risk of a dominant nodule in a multinodular goiter. A solid consistency, again, double the risk compared to a cystic one. And this is a big one. A nodule in a male carries a vastly higher statistical risk. We're talking 3 to 4 times higher than that exact same nodule in a female. Keep this rule in your back pocket for surgery rotations. It's a huge driver of clinical suspicion.
Finally, Section 5, Thyroiditis and Immune Responses. Let's unpack the conditions where the body's own immune system, or sometimes an outside infection, is the direct culprit behind the swelling.
You've got to know the contrast here for your exams. Hashimoto's thyroiditis is a chronic autoimmune war. High titers of antibodies cause relentless lymphocytic infiltration, massive destruction of the acini, and eventually fibrosis. It leaves the gland with this characteristic bossulated or bumpy feel and almost inevitably results in hypothyroidism. Now compare that to D. Corvain's thyroiditis. That is an acute granulomatous reaction, usually following a viral infection. It presents as a super painful, firm goiter, but the good news, it's largely a self-limiting inflammatory response that usually resolves on its own over a few months.
If you step onto the microscopic battlefield of Hashimoto's disease, what you'll find is this intense infiltration of lymphocytes and plasma cells invading the thyroid tissue. This isn't just mild inflammation. This is the active physical destruction of the thyroid acini by the patient's own immune system, which ultimately replaces perfectly good functional tissue with useless fibrosis.
Actually, before we wrap up, we cannot forget this incredibly rare but frankly terrifying etiology. Riedel's thyroiditis. It accounts for only about 0.5% of goiters, and it's basically a localized collagen disease. The normal thyroid tissue gets entirely replaced by dense, cellular fibrous tissue. And what makes it so devastating is that this fibrosis mercilessly infiltrates right through the capsule into the adjacent neck muscles, nerves, and even the carotid sheath. Clinically, it creates a rock-hard, fixed mass that perfectly mimics an anaplastic carcinoma.
So, to wrap up this explainer, I want to leave you with a provocative thought to tie this whole thing together. We've traced these swellings all the way back to their microscopic origins, whether it's fluctuating TSH, relentless antibodies, or specific oncogenes. How does precisely identifying that exact cellular origin fundamentally dictate a surgeon's entire management plan? Because understanding the why at the cellular level is exactly how you master the what to do next in the operating room. Best of luck with your MMC guideline review, Paul Eck. A huge thanks again to Dr. Bhavani Rao, sir, and to all of you, keep learning.